Kia ora koutou and welcome to the Goodfellow Unit podcast. I'm Dr. Helen Carr. I'm a GP. Today we are talking about fertility, covering some of the complex cases that we see in primary care. And to do this, I'm joined by Devashana Gupta, who is the medical director and a fertility specialist at ReproMed Fertility Clinic in Auckland, and is a private gynaecologist at Auckland Gynaecology Group. She is a RANZCOG subspecialist in reproductive endocrinology and infertility, and has been involved in a number of fertility trials and is published in the Cochrane Library Review of Evidence-Based Medicine. Hello, Devashana. Thank you so much for being here.
Kia ora, Helen. Thank you for that wonderful introduction. It's my pleasure to be here to talk to you today and hopefully impart some knowledge for our colleagues.
I'm excited to chat because I find fertility consults deceptively challenging. And there are really good health pathways and things, but I always find things are a bit more grey in real life. So keen to send to this discussion around some cases and we can kind of go from there.
Sure.
So the first one I'd like to start with is a 36-year-old single Māori heterosexual woman who has been career-focused for the past 10 years and has now come to us in primary care as she's kind of worried about her fertility. She doesn't have a current partner, but she's just wondering if she can get some general tests done to assess, how much time she might have left or how fertile she is. Is there such a thing we can do? And in general, what do you kind of want to know in your history and exam from this woman?
Yeah, you mentioned fertility consults being deceptively difficult or challenging, and same here. I mean, I'm a fertility specialist, but at times there are cases that kind of dumbfound you or you struggle. But not this one so much, because what's important to understand is it's challenging to know about fertility when someone's not actually trying to conceive. And commonly the test we do is sort of what you want to be targeting it towards is what is your ovarian reserve or what is your fertility potential. And what's made this very helpful and useful over the last decade or so is the AMH blood test. And an AMH blood test is an easily done test that they just don't have to do it at a particular time of the cycle. It is not funded, so patients do pay for that. But what we do is obviously see this patient, take a history, take a menstrual cycle regularity history, talk through her any sort of red flags that you might say. So does she have any history of sexually transmitted infections, any endometriosis symptoms? And what is her desire? Where does she see herself? What's her family planning like? Does she want to have one child or two children? And in that scenario, the initial test, among others, we would request would be an AMH test.
If they come to us with that result in primary care, what would be your advice on interpreting it?
Look, it's a nuanced test, though it is a gold standard. It's a nuanced test because it tells us what our potential is. It doesn't tell you if you are fertile or not. So what I always say to patients is it can either put you into a false state of panic or a false state of reassurance. Because if it's normal, yes, it tells you you have a good potential, good reproductive potential, but it doesn't tell you come 5 years down the track when you are keen to start trying that you will get pregnant. If it's low, it will tell us that you have a reduced window, but it does not tell us that you're infertile. And we offer free 15-minute consults with a doctor as well. And one of the most common consults is, can I do an AMH test? Or I've done an AMH test and this is what it is and what does it mean? And quite often I've had people who've had AMHs of less than 1.1, which is the lowest reportable, and they weren't trying to conceive. And then they panic and then they start trying, truncate their career, truncate their study or whatever, and they're fall pregnant. So that comes back to the sort of the relative difficulty in interpreting an AMH. So what you want to do is you want to tailor that result to what their desires are and where are they in their family planning journey. And therefore, we have a graph. There's lots of graphs, but if it's in the red zone, which is low zone, green is normal, orange is high for ours. But plot that on a graph and then tell them, yep, this is your reproductive potential. This tells you your window, but it does not tell you whether you're fertile or infertile. Fertility is obviously a multifactorial process, right? So you need a partner, you need sperm, you need tubes to be patent. So they need to take everything into context.
Who are the particular groups that you find it particularly useful in?
I would say it's useful in anyone that we are seeing that we are planning to start an IVF cycle on, because it helps us tailor the dose of stimulation so that we don't overstimulate them. But outside of an IVF cycle, it is helpful for anyone who is considering having a family or wants to know, can I go, on OE for 2 years and, I want to have children. Do I need to talk about freezing my eggs before traveling, or do I have that time? It might also be useful for someone who's maybe even had a child and planning on whether she has a longer gap between that child and the next one and is just considering options. So it is helpful for any sort of family planning decisions or fertility planning decisions. But all I'm saying is it has to be taken with a grain of salt. Yeah.
And if we were to explain it to our patients, if they're asking us to kind of give us an explanation for what it actually is testing, what kind of spiel do you use for your patients?
So we say an AMH assesses your ovarian reserve. So it tells us how many eggs you have left. Now it tells us the quantity of eggs, but not the quality of eggs. So it's important to outline that because the quality is still dependent on our age. So someone at 40 with an excellent AMH in the orange zone, so above average ovarian reserve, they're like, yeah, I'm sweet. But what they must understand is they are 40, so at least 40% of their eggs are going to be abnormal. So we need to take into consideration the aneuploidy or the chromosomal abnormality rates. So it comes down to age. They need to understand miscarriage rates increase the older we get as well. So yeah, it's about understanding it in the context of where they are in the journey, and just not being completely reassured with an above average egg count, which might in itself reflect polycystic ovaries. But the other factors to consider could be your partner. When you do have a partner, might not have very good sperm, and you've got a good egg count. You've left it 5 years, and now you found that your partner is, azoospermic or has absent sperm. And so, yeah, it's about understanding it, and also using that to plan your journey and plan your family potential.
Based on our patients' demographics or age, possibly ethnicity and medical background, do we have some data within New Zealand about being able to estimate this many percentage of women might struggle with conceiving? Do we have that data available to us?
So NZAD, which is the Australia-New Zealand ART database funded by the University of New South Wales, they report all of this, and it's still kind of sitting with about 1 in 5, 1 in 6 couples affected by infertility. And so that's about a 15% rate, and New Zealand is seeing similar. Though access or treatment undertaking has increased over the last report. So saying maybe more people are able to access treatment either privately or publicly, or more people are aware. We don't know that for sure. But what we do know is that fertility rates do decline the older we get. So they're declining since you were in utero, but more rapidly after 35, which is interesting. When I talk to my patients, I'm like, when you were in your mom's uterus, you had about 7 million eggs. By the time you were born, you had 1 million. By the time you reached puberty, you had 500,000. Of those, we only use 4,000. So it's a very non-efficient process, right? So they are declining, from the word go. So it's about understanding, aneuploidy, increasing age. And it's also not just women. WHO says that in the next 50 years or so, more than 50% of men would be infertile or have some degree of subfertility. And that's just because of what we're exposed to in our day-to-day lives, like endocrine disrupting chemicals or EDCs, which is one of my pet topics, which is everything we're exposed to, probably this headphone that I have in my ear as well. But it's about, prolonged exposure rather than, one immediate exposure. So I think the data is there, and I think there is increasing information being available that men previously under-recognized in the journey do need to be included, and therefore are becoming increasingly aware of this and do need to be tested early as well. Sorry, I did digress from that initial question, but...
And we will be covering that in a bit more detail.
Yeah.
So you've got this woman in front of you. You've talked about the AMH test as being an option, and then got a bit of her past gynecological history. Is there anything else during that consult that you think is really important for us to elicit in either the exam or the history?
Yeah, so of course we talked about men, so partner history if they have a partner. If no partner, obviously past medical history and family history is important as well. If they have a family history of premature ovarian insufficiency or POI, that's important to elucidate. use of any medications that can impact fertility, or past history of any chemotherapy or any surgeries that could have had an impact on fertility is also important. At our level, what we tend to elucidate is what their family size is. So I will say to my patients, plan for your last child rather than your first child. So if you want a 5-child family, then you're probably better off trying now versus, delaying it. In terms of examination, obviously a BMI is important. We know BMI plays a big role in fertility, antenatal outcomes, birthing outcomes as well. And then, of course, you guys at GP level would always be checking the blood pressure and everything else. We refer often for a pelvic ultrasound, and A, that's often to just make sure there's no general abnormality, but B, you can also look at antral follicle count or AFC, which used to be used a lot more. It tells us how many, what your ovarian reserve is, but it's probably superseded by the AMH nowadays. And then, of course, generally we do a cervical screen to make sure that, you're treating the holistic patient rather than just tunnel visioning.
And that's one thing that we're really good at, is sort of trying to get a broad picture, I think, before we send them off to you.
Absolutely.
I hope.
Absolutely.
And if you were
kudos to you guys on that. Yeah.
If you were giving some specific advice, so things in general that this woman could do to optimize her chance of conception, what would be the top things that you would recommend?
Lifestyle, and within lifestyle would be eating a good diet. So Mediterranean type diet has been prioritized, I suppose, as being beneficial for fertility. Exercise, so 120 to 150 minutes of exercise a week has been beneficial for fertility. Minimizing your endocrine disrupting chemicals, so stopping smoking, stopping vaping, minimizing alcohol and caffeine. So that's one. Second would be about inner partnership, if present, then regular timed intercourse. It's quite a fair portion of patients don't know their fertile window or when the right time is or how often they should be having intercourse. Quite often you'd have patients that are just doing once a month around ovulation and they think that's enough. And then thirdly, it's about her understanding her reproductive potential and the fact that she has the ability to reach out and seek help whenever she needs to. Normally we'd say under 36, you can try for a year. And then over 36, we'd say to try for 6 months before seeking fertility assistance. Now, obviously, that won't be funded as a public appointment under the Northern NRFS scoring criteria, but they are able to seek that privately.
And just a quick aside on those ovulation sticks that you can buy at the chemist. Do you find that they have a role for people to figure out their fertile window?
We have quite often got similar questions. I'm using this stick. It's not always showing I'm ovulating or I'm doing my temperature or cervical mucus. I think there's a tendency for other people not to do anything at all or doing everything. And that creates a lot of anxiety. That creates a lot of stress and that creates performance anxiety in the partner as well. So yes, they do have a role, but I say they're not be all and end all of it. I say, have regular intercourse 2 to 3 times a week. Enjoy your sexual life. Don't make it a chore because it makes it harder for men. And then you lose the whole joy of intercourse, right? Because you're saying, yep, it's the time now, let's do it. So yeah, you could use all of that, but I'd say just, follow your calendar. If you have a 28-day cycle, you're ovulating around day 14, day 15, start having intercourse around day 10 every day or every other day, and you're pretty much covered. So yeah, short answer is you could use it, but I don't think it's like, it must show ovulation.
So when we do refer, what sort of things are you looking for? What's useful for us to provide in details for a referral?
Yeah, so time to trying is useful. And of course, any preliminary investigation. So generally speaking, a day 2 blood test, luteal blood test of progesterone if regular cycles, and then a semen analysis. And then potentially any past medical history or medications, because often patients come and they're not 100% aware of what they're taking. And if it's not on Care Connect, then we often aren't able to access that. So yeah, that would be helpful. I think a list of medications for sure.
In this case, if this woman was in a single-sex relationship, what would be different, I guess, with your approach once they see you or regarding public funding? Do you know?
Same-sex relationship, obviously, you have 2 potential ovarian reserves to take into mind. You have to understand, do both want to be involved in the fertility journey or one or the other? But there is funding for same-sex couples. There's potentially 2 pathways. One is if they have a biological cause of infertility, either one, then they can go into the journey, but the primary person with the biological infertility has to have the treatment. The other pathway is they have to do some private treatment or some home treatment plus private treatment. So home insemination plus private IVF or DIUI. And then once they've done a certain amount, so usually either 6 home inseminations plus 6 clinic DIs or 2 completed IVF private cycles, then and not pregnant and had a baby, then they can be scored for public funded treatment, as long as obviously they fulfill the other CPEC scoring criteria such as BMI, age, and smoking status.
Was there anything else within that case that you wanted to talk about?
Yeah, and I think we didn't cover the rainbow community. So there are clients or couples who might be going through gender affirming care, and those would be needing egg freezing. So egg freezing is currently not funded under the government scoring criteria because any transitioning from a cis female to a trans male is reversible once you stop the testosterone therapy. Whereas obviously on the other side, any transition to a female does lose the sperm production ability. So therefore that is funded. So we do see, gender affirming clients who freeze their eggs beforehand. And then of course, any egg freezing for a client who's potentially an egg donor for a 2-dad family is also crucial to understand. And these 2-dad families unfortunately don't have any public funding, so they do go through an arduous journey where they have to find an egg donor, they have to find a surrogate, they have to go through an ethics application. So sometimes they might have someone who they know who wants to freeze the eggs before all of that process starts. So yeah, I think it's important to understand the whole rainbow community and where sort of the eligibility lies.
So are you happy if we go on to the next case?
Yeah, sure.
So we've got a 28-year-old woman who has been on the depot since she was 16. So she doesn't really have a good sense of whether she has a regular cycle. She's come off it, say, in the last year, but again, periods haven't returned to a regular cycle. She's possibly had a bit of mild acne as a teenager and some weight issues generally, but she's never had a pregnancy. She comes to you, she's diagnosed herself with PCOS based on some reels she was given on Instagram. So she's wanting a referral to fertility because she thinks there's a good chance she's infertile or subfertile. So a bit of a complex case, but keen to talk a bit about, subfertility in the context of oligomenorrhea or where we go from here, where you start with this.
So yeah, oligomenorrhea or absence of regular cycles, again, a common scenario in both fertility and gynae clinics. Now, this woman, obviously, you need to take into account her whole health history. So is a BMI a factor? You said she isn't very sure about the regularity of her cycles from very early on. So does she have oligovulation because of PCOS, which is the most common cause of oligovulation in about 15 to 20% of women? Or is there other causes of this? And then, of course, is she taking any medications, or is she hypothyroid? Has she got a prolactinoma? So your history and your examination would be targeted towards finding causes. And I'm sure as all GPs and as fertility specialists, the first thing is she pregnant? And she just doesn't know she's pregnant. So HCG test obviously is part of your workup in that scenario.
What would be your highest yield investigation in this woman?
So as I said, HCG test would be the first test we'd do. We do reproductive hormones as well, so an FSH, LH, together with the estradiol. Estradiol is very crucial in us understanding the FSH and LH, and sometimes it's done without it, which makes it a bit hard to understand. So I always emphasize about doing that together. if she has regular cycles, which I know she doesn't, luteal progesterone would be helpful as well. So together with that, your other high yield investigations would be a early morning prolactin, your thyroid function. So obviously you're targeting your investigations towards the potential differential diagnosis. So PCOS being the most common cause, you'd be doing your androgens as well. So just a testosterone, not in the luteal phase if she has regular cycles, or just a random testosterone. And then as fertility specialists, if that is elevated, we are able to then order further specialized androgens to that, such as DHEA, 17-OHP, etc. We would encourage an ultrasound, though not entirely necessary in the initial workup. An ultrasound can be helpful to pick up any sort of polycystic appearance to the ovary, so 20 or more follicles in one ovary. And then, of course, looking at other potential causes, so investigating that, such as metabolic, HbA1c, is she hypo, so your FSH will tell you that as well.
In these slightly grey areas where there might be a bit of hyperandrogenism with some acne, and so BMI of 30 or mild obesity, and then this masking of the depot, kind of meaning we can't get an accurate history, period history. What do you find important for clinching the diagnosis of PCOS?
Yeah, that's tough, isn't it? Because you have that masking of the depot, so you don't know, is it just a post-depot effect? But 6 to 18 months after the last injection, you should get return of periods. Definitely by 2 years, you would have expected this woman to have had a cycle. And if she doesn't, then that's pointing towards 99.9% likelihood that it's not depot related, and that we do need to investigate further. So I think your Rotterdam consensus criteria was modified to the Gene Health International consensus criteria, which says that you need sort of 2 out of the 3, so either polycystic appearance to the ovary, so that's 20 or more follicles in one ovary with no dominant follicle, oligomenorrhea, so anything outside of a 21 to 35 day cycle, and then either hyperandrogenism clinically or biochemically. And then, of course, you need to rule out other factors such as any adrenal tumors. So I think doing a testosterone and an ultrasound at this point in time would help you make that diagnosis. And even if just one of them is positive, with her irregular or absent periods, you do have your diagnosis.
And then what would you tell her regarding her worries about fertility in relation to having PCOS? Is that a common problem for women? Are there any things that make it more likely to be a challenge for certain people with certain PCOS phenotypes? What would be your approach to that?
Yeah, so PCOS, once again, I'd reassure her that it is common, sort of probably one of the most common causes of irregular cycles and ovulatory causes of infertility. We always talk about weight management as one of the crucial first steps in managing this. And they say even a 5% body weight reduction might find resumption of normal cycles. And then we talk to her about how she can manage this. If PCOS is confirmed, it is a lifelong diagnosis, and what you need to manage is the phenomena or the stigma associated with that. So potential stigma could be the hyperandrogenism or hair. Mostly cosmetic measures would help with that. You can use things like spironolactone or finasteride, but of course they are a contraindication to getting pregnant because they can cause harm to the fetus. Secondly, the irregular cycles. So if she's trying to get pregnant, that can be easily helped and managed by maybe doing ovulation induction, so using letrozole. And the side effect or the positive outcome is that if they do ovulate, then they start getting regular cycles with that. Now, that's the gold standard treatment. Other options are someone can't afford that or is geographically limited, then they can just take metformin, which can be prescribed at a GP level, and ideal to get to up to 1 gram QID or 4 times a day to achieve benefits, though it's inferior to letrozole. And then the other stigma is obviously, I have this diagnosis, the psychological, emotional trauma associated with that. And studies have shown that PCOS can be psychological, demeaning to patients, both because of maybe hyperandrogenism, overweight, or irregularity of cycles. And it's about addressing that and reassuring them that, look, hey, This is not rare. It is common. It is easily manageable diagnosis. And if you were to have a fertility diagnosis, this is probably the better one to have.
If we manage to get someone ovulating regularly with PCOS, say on high-dose metformin, do they then still have a higher chance of having fertility issues? Or is it just related to the anovulation that is the rate-limiting step?
Yeah, so if everything else is fine, tubes are checked, sperm is okay, then yes, it is the one rate limiting step. There is associations with antenatal outcomes though. So of course, an increased risk of GDM or diabetes, and then miscarriage rates is a gray area, can potentially be increased. And some studies show metformin might be beneficial in that scenario, some don't. But generally speaking, metformin is safe to continue in pregnancy.
Have you seen any rise in the use of GLP-1s for weight loss to help with fertility?
Totally. We have so many.
Topical question.
Yeah, we have so many patients that come and they're on Wegovy or Manjaro or whatever equivalent there is. And as you know, it's a new medication, right? And we don't know the impact on pregnancy or fertility. We think there is no impact on fertility. But generally speaking, we say they should be off it for about 6 to 8 weeks before trying to conceive or even consider freezing the eggs. This is based on probably no strong data or studies, probably just recommendations by the pharmaco. So, yeah, I mean, if I'm seeing a patient with PCOS in my gynae clinic and they have struggled to lose weight, not trying to get pregnant, then yeah, GLP-1, absolutely go for it. If it helps you get to a stable weight, and then that's when you want to start trying for conception, then we say to come off it and hopefully you maintain that weight loss. But yeah, generally the recommendation from fertility specialists and obstetric physicians is to stay off it for 6 to 8 weeks before conceiving.
And I guess I'm keen just to chat a bit about the inequities that we do see in New Zealand with Māori and Pacific communities often either presenting quite late, not necessarily recognising it, or coming after 5 years of trying rather than just the 6 months. Yeah, do you have any suggestions or things that we could be doing differently in primary care to help reduce these inequities?
Yeah, it's a good question. And it's a tough question because we know the inequity is there. And as healthcare, we are, working on that to try to improve it. But things move slowly, unfortunately, in the system. Recently, I had an email about a study done by a Pacifica community through the University of Auckland looking at Pacifica communities and fertility. So there is work being done. And I think there's few barriers that we need to look at here. Obviously, there's the geographical barrier there where there might not be access to fertility clinics that are close to where these communities live. There are financial barriers to costs if it's not funded. Then there's the funding barriers as well. Unfortunately, there is a BMI cap for public funding. Unfortunately or fortunately, that's a debatable topic. And that's a topic that's been another one of my pet peeves for a while. But for female, the BMI cutoff is 32. For men, the BMI cutoff is 40. So yes, they can have a consultation up to a BMI of 35, but they can't have access to treatment. There is some degree of clinical override that as fertility specialists that we can have for Māori and Pacifica to provide that access because, again, let's not discuss BMI, right? It's not an individual assessment tool, it's a population assessment tool. So, yeah, so the inequities around that is present. Then there's inequities around, in our medical environment, in our clinics, there's a lot of medical terminology and jargon that might not be culturally appropriate or sensitive, or they might find it difficult to understand. And we need to be able to provide this information in a layman's term that is easy to understand. Maybe to also provide written information in certain languages that provides easier access to them. And then also reducing the fact that ART is bad or, it means that they are inadequate. There needs to be understanding that, family planning affects everyone. And it's not about that you need fertility and therefore this must be a bad thing. It's about everyone's affected by infertility. In fact, this study that I mentioned showed that Pacifica couples were higher in the incidence of infertility than New Zealand European people. And there is this misnomer or misunderstanding that we think that Pacifica people are more fertile.
Do you know the difference in the rates? It would be important to know.
Yeah, I think it was around 12% for females, and in comparison, women were 9%. And similarly, men was about 15% in comparison to about 8% or something thereabouts. So I don't think the numbers were statistically significant if you do a whole database review, but they saw that in New Zealand in the people that responded to their survey. So they did what we call a talanoa, and then looked at all these Pacifica clients, and they found that when they compared that to the NZ data and the New Zealand stats data, that it was slightly bit higher, which I found news to me as well when I read the article.
Do you think that in general, asking women of reproductive age about fertility is something that we can do in primary care a bit more often, maybe to reduce stigma, and any tips on that kind of conversation?
Totally. Look, I think what we're all doing very bad at is starting this discussion very early on. In school, we are all taught about, contraception, don't look at a boy, you'll get pregnant. What we're not taught about is, that our fertility declines with age, and we need to treat a couple. And as you said, at GPs, you guys treat the holistic patient, and that's great. And I think what we need to bring in is, hey, look, you're 35, you've come to me for acne. Have you considered having children? What are your family planning plans? That fertility declines. So I think we all could be doing a better job. So if I'm seeing someone in my gynae clinic, and if they're of the reproductive age, I try and remember to say, hey, look, you're 32, what are your plans? So I think we should all be doing a better job about educating our patients, even if they're not coming for fertility, about remember that, if fertility is declining for females, even men as well. Okay, so we say that men are infertile for life, but no, yes, they are, but with a disclaimer in that their fertility also declines with age, and there are chromosomal issues and single gene disorders that increase with increasing age as well.
Great. What would be your 3 key take-home messages for our listeners?
Yeah, I think it's about treating the patient client as a part of an equation of potentially 2, and, diagnosing and treating both, but not forgetting about crucial lifestyle factors. So BMI, endocrine disrupting chemicals, smoking, exercise, and weight, and about talking to every individual where, not obviously a postmenopausal woman, but where relevant, about, what is your fertility desire, and do you want to look at doing an AMH, understanding the nuances of an AMH though. So they're going into it with an informed decision.
Great. If you're a New Zealand GP and would like to claim CPD points for listening to this episode, our podcast is eligible, so please log them. You will find links to any relevant resources that we've discussed in this episode on our website at goodfellowunit.org. And if you'd like to get in touch, we do value your feedback, so you can email us at podcast@goodfellowunit.org. Thank you for listening.